So obstructive lung disease. Obviously from the name, something's obstructed in the lung. And the thing that's obstructed is the airways. Okay, so I'm drawing out the trachea for you and the bronchi. This is the bronchi splitting up. And so if these airways are blocked up, guess what's going to happen in the lungs? Air can't leave. You're going to get air trapping. Air is going to get stuck in the lungs. And so your total lung capacity, the volume of air is going to increase in your lungs. Your lungs are going to balloon up because you get increased total lung capacity. Now there's going to be 4 diseases we're going to talk about that cause obstruction in the airways. First one is called chronic bronchitis. We're going to see all of them in a second, so you don't have to note this down. Chronic bronchitis. Number 2 is emphysema. Number 3 is asthma. And number 4 is bronchiectasis. All of these diseases cause an obstruction and prevent air from leaving the lungs. Some of them don't even necessarily cause an obstruction. For example, this one doesn't cause obstruction, but it prevents air from leaving the lungs, and that's how we call obstructive lung disease. These two are termed chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. Okay, COPD can be subdivided into these two: chronic bronchitis, emphysema. Okay, so when we talk about COPD, we're referring to either chronic bronchitis or emphysema. But when we're referring to obstructive lung disease, it can be any of these 4. Any of these 4 can obstruct. It's just that these aren't chronic disease. These aren't chronic diseases. Okay, so a couple more things on testing. What we can do is we can test people. We can test their pulmonary function, call it pulmonary function testing. And the couple things that we're going to look at is we're going to look at FEV1. FEV1 looks at how much air can you blow out in 1 second, okay? And then the other thing we can look at is FVC. What did we say FVC was? Remember, FVC was the maximal amount of air that could be expired. So you fill up your lungs as much as possible, take as deep as breath possible, and you blow it as hard as you can, as long as you can. You push out as much air as you can, and that's your FVC, okay? FEV1, how much air can you blow out? If you blow it as hard as you can, you do the same thing, but you just measure the first second. How much air came out in that first second versus how much total air can you push out if you have all the time in the world. That's your FVC, and that's your FEV1, that's your FEVC. Okay. Now, what's going to happen to this what's going to happen to FEV1 in an obstructive lung disease? Well, the whole point of this was that we can't get air of the lungs, so obviously this one goes down. And FVC, what's going to happen to that? What's your total amount of air that you can push out? Again, it's the same problem. You have a problem with your lung disease, so this goes down. And the problem here is this obstruction is even worse for this than for this. Okay, eventually if you push hard enough, you might be able to just pass this blockage. So the FEV1 is affected more than FVC. Now what we really like to look at is the FEV1 to the FVC ratio. Okay. And because this one is decreased more than FVC in obstructive lung disease, in obstructive lung disease, this ratio decreases. Normally, the ratio is 70 to 80%. Okay. In an obstructive lung disease, this ratio is less than 70%. Okay. This is actually very key. If this ratio is less than 70%, if they tell you on the question stem you have the FEV1 and they tell you the FVC, and you calculate that ratio and you see this less than 70%, you know you're dealing with an obstructive lung disease. So that helps you a lot. Okay. So a decreased FEV1 FVC ratio less than 70% is hallmark of obstructive lung disease. Now I'm also going to note that we have something called a restrictive lung disease. We're going to talk about that in the next video. But that's a problem with just basically the lung expanding and filling up with air. This one's a problem with the lung emptying its oxygen. In a restrictive lung disease, this ratio will actually be increased. I'll explain why later, but in that case, it'll be greater than 80%. So greater than 80% restrictive, normal 70 to 80, and then obstructive is less than 70%. So now let's talk about these. We're going to go into this chronic bronchitis first. Chronic bronchitis, it's defined by its symptoms, which is having a productive chronic cough for at least 3 months in a year for 2 consecutive years. So you have to have a chronic productive cough, so sputum's coming out for at least three total months in a year, and it has to be 2 years straight. Okay, and the reason why you would have a chronic productive cough would be due to irritation and inflammation in the lung airways. That's going to cause proliferation of goblets of mucus secreting glands in the bronchi. Okay, it's going to be inflamed. You're going to have a bunch of extra mucus secreting glands. They're going to make too much mucus. As you can see here, this nasty little mucus stuff, and it's going to plug up the airways and it's going to prevent airflow. So in this disease, inflammation leads to mucus production and obstruction of airflow. And what you're going to see is very characteristic here, this very high yield, is a read index greater than 50%. What does this even mean? This means that the mucosal gland layer makes up over 50% of the thickness of the wall of the bronchus. So let's say the wall of the bronchus is this thick. At least over 50% of this, so this stuff is all mucus glands. And that's obviously abnormal. It just doesn't look right if you have all these mucus glands making up over 50% of the whole wall. And that's, if you see that the read index is over 50%, that's also very, very characteristic of a chronic bronchitis. How do these patients present? Well, the classic word is called a blue bloater. The reason they're blue is because they have cyanosis, because they're not getting enough oxygen. Okay, they're not getting oxygen. There's a VQ mismatch basically. Okay, there's not oxygen's not coming out, oxygen's not getting in. Sorry, oxygen's not coming out, oxygen's not getting in. So this blood is gonna go to the lungs, but whatever air in the lungs has already been extracted of all its oxygen. There's like not enough new air with new oxygen coming in. So they have cyanosis because the blood's not getting oxygen. So they also have bloater because eventually their right heart's gonna fail. It's gonna be pumping against high pressures in the lungs, so they're gonna get edema and they're gonna call blue bloaters. The other things you see, you're going to see it for all these obstructive lung diseases, okay? You're going to see shortness of breath. You're going to be seeing tachypnea. They're going to be breathing faster than usual because they're not getting enough oxygen. You have cough. As you can see, your chronic productive cough. And you're going to see wheezing. It's going to be all the same. It's not going to help you define anything. Shortness of breath, but it's going to help you. These are all symptoms of chronic obstructive lung disease, okay? Again, the defining features here, though, are really the chronic productive cough for so long, read index greater than 50%, and then these guys are the blue bloaters. Next, we're going to go to emphysema. Emphysema, the problem here is the destruction of alveolar air sacs and destruction of elastic tissue, and it's due to an imbalance of proteases and anti-proteases. Okay? And the imbalance is specifically with the overactivity of proteases. So the proteases are going to chew up all these elastic tissue. You're going to lose elastic tissue. What's going to happen? What do we say about elastic tissue and compliance? Remember, they're opposite. So if you have less elastic tissue, you have increased compliance. And so your airways are going to collapse on expiration. They're not going to be as stretchy. They're not going to be able to keep open. So they're going to collapse on expiration. So what you're going to get is you're going to get air trapping, because air can't leave because your airways just collapsed. And you're going to get inflation of the lungs. Okay. Loss of elastic tissue leads to airway collapse. And then, because these airways collapsed, okay, then this air is not going to be able to go out. It's going to stay in there. It's going to be trapped. And you get inflation of the lungs. Okay. Causes of emphysema. Smoking is the most common cause, and because the way it does is it leads to inflammation. Inflammation activates the proteases, and you're going to get central acinar emphysema in the upper lobes. You can remember this because, first of all, smoke rises, so smoke's going to go this way. It's going to damage the upper lobes of the lung. And okay, first of all, what is the acinus? Acinus basically refers to this. It refers to alveoli plus the respiratory bronchioles, okay? Central acinar means only this part is affected. It's more central. It's more close to the middle, okay? And that's because, if you can think about it, smoke's going to have more trouble getting farther and farther. Smoke's going to slowly diffuse, and it's cause damage, and it's not going to get all the way to the end. So you're only going to get damage all the way over here. Okay, so you get central acinar emphysema in the upper lobes. That's from smoking. The other cause of emphysema is called alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin normally it neutralizes proteases. That's why it's called an antitrypsin. It's an antiprotease. If it's missing, which is it's a congenital problem, what you're going to get is you're going to get activation of proteases. Proteases will be overactive, and so you're going to get destruction of the elastic tissue, and you're going to get a pan-acinar emphysema of the lower lobes. Okay, smoking, upper lobes, alpha-1 antitrypsin deficiency, lower lobes, and it's all of it. All of it gets damaged because now you have proteases everywhere. They're going to be all active. You're going to get this damage, and you're going to get that the emphysema, a pan-acinar emphysema. The other thing you're going to see with the alpha-1 antitrypsin deficiency is you're going to see liver cirrhosis. This is explained in the GI section. I may as well just explain it now. Basically, the reason why you're missing this alpha-1 antitrypsin is because your hepatocytes can't secrete it out. So your alpha-1 antitrypsin is sitting here, okay? And it can't secrete it out. That's the whole problem here. So it's going to accumulate, and it's going to mess up your hepatocytes. Your whole hepatocyte's going to die, and you're going to eventually get too much dying of your hepatocytes. You're going to get liver failure. Your liver's not going to work very well, and you're going to that's basically liver cirrhosis. So if you ever see liver cirrhosis and emphysema, your answer is alpha-1 antitrypsin deficiency. Now the way these guys present is they're called pink puffers, okay? They have barrel-shaped chest that, again, remember the whole problem, they get air trapping, okay? Air is going to stay in the alveoli, so it's going to balloon up, and their chest is going to look like a barrel. They're going to be they're exhaling with pursed lips. And what this does is pursed lips increases the pressure in the airways, okay? And increasing the pressure in the airways then will prevent their collapse. If you have more pressure in this airway, increased pressure, then the pressure causing it to collapse is going to be resisted. And the other thing that's going to happen is these guys are going to be thin. Okay, they're going to have increased work of breathing because they're pushing really hard trying to keep their airways open. They're burning a lot of calories doing it, so they're going to be thin. They're going to be barrel-shaped, thin, exhaling with pursed lips. And again, the other symptoms that we always see in obstructive lung disease is just respiratory distress, shortness of breath, tachypnea. What else do we say? Cough and wheeze. We see this in all the obstructive lung diseases, but this is very characteristic of emphysema. Okay, so again, emphysema from smoking, centroacinar emphysema from alpha-1 antitrypsin deficiency, pan-acinar emphysema in the lower lobes. Okay, asthma. Asthma here this is key. Hyper-responsive bronchi to stimuli. And they get a reversible bronchi constriction of the airway. So this is our trachea, and then we get our bronchioles, and we have a little allergen that comes in. And remember, our bronchi have smooth muscle. They can constrict or they can dilate, and they're going to be if you have a hypersensitivity, if you're too sensitive to whatever stimuli, it can be just some pollen, it can be cat, it can be just cold. Your bronchi, people with asthma, their bronchi will constrict. And if it constricts, then air is not going to come out very well, okay? So that's a bronchial constriction. And the key word here is going to be reversible. Stimuli goes away a little bit, eventually they go back to normal, okay? Now they're back to normal. They have normal bronchi, they don't have any obstruction. You have stimuli, constriction, obstruction. Stimuli goes away, reversal, back to normal, okay? Most often triggered by an allergic stimulus, okay? And this is a type 1 hypersensitivity reaction. Remember, type 1 hypersensitivity, what happens there? Remember, allergen induces release of IgE. IgE activates mast cells, and mast cells will release inflammatory substances, and those inflammatory substances are going to cause this bronchial constriction, okay? So, how does this present? You're very familiar with asthma. It's very easy. The key thing here is it's going to be in childhood usually. Often, not every time, but usually. Okay, and often this kid has other atopic diseases. So, what are other atopic diseases? We like to call it the Atopic Triad. So, asthma, which obviously eczema, and allergic rhinitis. So they're more susceptible to allergic reactions to different things. So they have skin stuff, they have allergic rhinitis, they have asthma. Usually, a lot of times they have a combination of some of this. So on histology, if you look at the lungs, what you're going to see Kirschmann spirals, let's erase this, and charcoal-laden crystals. Okay, Kirschmann spirals you can Google. These are charcoal-laden crystals. If you see these, you're going to know it's asthma. Okay, and the way you diagnose it, again, is you do spirometry. Now, what's the test? Have you ever heard of the test that you do to diagnose asthma? Because let's say you do a pulmonary function test, okay? Will it be normal, or what's it going to be? Well, a lot of times, guess what? Your pulmonary function test is going to be normal. I just told you that a lot of times whoever has asthma, usually this kid is just going to be normal. They don't have a stimulus. Their bronchi, they're not going to have obstruction. They're only going to obstruction due to a stimulus. So if you test someone that's normal, you haven't ruled out asthma yet. You need to stimulate them. You need to test them out. And what you do is you give them a methacholine challenge. Methacholine is going to cause constriction of the bronchioles. And so methacholine is, if you see that they have constriction of the bronchioles with this methacholine, then you can diagnose the asthma. And what was the FEV1 to FVC ratio that we need to see? Remember, the answer is we need to see less than 70% for us to be able to diagnose an obstructive lung disease. Okay. And just to be clear, the thing is that these patients with asthma, they're going to be hyper-reactive to this methacholine, and that's why they're going to get this bronchoconstriction, and they're going to get that obstruction. Alright, finally is bronchiectasis. Bronchiectasis is a permanent dilation of the airways, and is due to a chronic necrotizing infection. So permanent dilation of the airways, chronic necrotizing infection. Those are the key things to know here. You can see here there's these super dilated bronchioles. The airways are super dilated. Okay. And the reason why you get this permanent dilation is you get a local infection or inflammation that recurs or persists. And it can recur or persist for various reasons. You can have inadequate clearance of secretions, you can have impaired host defense, you can have airway obstruction. So if you have all these secretions that are just sitting there in your lung tubes, airway tubes, the bacteria is going to grow there and you're going to get an infection. Okay? And what's going to happen is you have, let's say you have infection, inflammation, you get damage to the airways. Sorry if you can't read this, I'm trying to write fast. You're going to get damage to the airways, you get dilation, and now you have accumulation of more substances, accumulation, because now your things are dilated, and now you're going to be at more risk for infection. So this really nasty cycle that's going to lead to recurrence or persistence of infection. That's going to lead, so it's a chronic necrotizing infection, and you're going to get permanent dilation, okay? And the key thing here is you're going to see foul-smelling sputum, because again, you have all this infection, and you get foul-smelling sputum. Okay. Again, I just want to emphasize, they don't only have foul-smelling sputum. This is obstructive lung disease. They can have anything. They can have any of those respiratory symptoms. They have shortness of breath. What were the other ones that I talked about? Tachypnea, cough, wheezing, all seen in obstructive lung diseases. Now that I've covered all the obstructive lung diseases, this is a whole review chart. If you want, you can test yourself with me. You can just do it by yourself, or you could just skip to the next lecture. But chronic bronchitis, what is the pathology? How do we define it? Remember, it's a chronic productive cough, and what's the time length? It needs to be at least 3 months in a year, and it has to be at least 2 straight years of those 3 months. Okay? And basically the irritation and the inflammation will cause proliferation of mucus secreting glands and overabundance of mucus, which are going to plug up your airways. And what's your read index going to be? Remember, your read index is going to be over 50%. Over 50%. And what's the... Okay, let's go to emphysema now. Emphysema. What's the problem here? Emphysema was the destruction of alveolar air sacs and elastic tissue. And I don't think I drew this clearly enough. But normally you have all these nice little air sacs, okay? But emphysema, remember, we have the imbalance of the proteases, too much protease activity. You're going to destroy the stuff, these barriers in between them, and you get one fat air sac. And I like Pathoma's analogy. He says it's like a big plastic bag. It's going to be floating, it's going to be weak, and it's not going to be able to get air out. That's going to be the problem here. You're going to lose all that elastic tissue, and the airways are going to collapse on expiration. And basically, you get airway collapse on expiration, and you get air trapping. It's too much air in your alveoli. You're going to have hyperinflation of the lungs. Okay, so that's all the way up to here. I just talked all about this. Now, smoking, what does that lead to? Smoking, what kind of acinar emphysema and which lobe? Remember, smoking leads to the centra because the smoke can't get all the way to the distal part of the acinus. And then remember, smoke rises, so it's in the upper lobes. Now, alpha-1 antitrypsin deficiency was the other cause. Remember, this causes that pan-acinar emphysema in the lower lobes. Let's call it lower. Okay. Asthma. Asthma, the whole problem here was hypersensitive bronchi to stimuli. And what type of bronchoconstriction was it? That was the key thing. It's a reversible bronchoconstriction. So a lot of times these guys are normal, no problems, and you get an asthma attack. That's why you can't breathe, because you have constriction and obstruction of your lungs, of your airways. Most often triggered by allergic stimulus. And what kind of hypersensitivity reaction was this? This was a type 1 hypersensitivity reaction. What was the problem in bronchiectasis? Remember, bronchiectasis was a permanent dilation of airways. And what causes this permanent dilation of airways? Remember, it's a chronic necrotizing infection, and it's an infection that either persists or keeps on recurring. Okay, and you have risk factors for that. The reason why it keeps recurring or persists is because you have inadequate clearance, you have impaired defense, impaired immune system, or you have an obstruction of the airways, something like a tumor obstructing the airways, causing the secretions to build up, and you get infections. And you get the little vicious cycle of infection, damage, and you're more at risk for infection again. Now, clinical symptoms. Remember we said, again, everybody can have shortness of breath, tachypnea, cough, wheezing. Chronic bronchitis, we see the blue bloaters. They have cyanosis from the VQ mismatch, and then they get bloated, they get edema because of their heart failure, right heart failure. Emphysema, what was the key term for that? Remember? Emphysema was pink puffers. Okay, the puffers, they're puffing, so they have the pursed lips, they have that barrel-shaped chest, and then they're really thin because of the increased work of breathing. Asthma presents in childhood, so if you have a kid with obstructive lung disease, he's a child, then it's probably asthma. Histology, what were the two key things you see on histology? Kirschmann's spiles, charcoal-laden crystals. Okay, and how do we diagnose this? What was that test we use? We used methacholine challenge. Okay, and then finally, what was the key thing for bronchiectasis? What was that key defining feature that we'll see? Remember, it's a bunch of this nasty infection, so you're going to get foul-smelling sputum. Alright, so that's it for obstructive lung disease. Next, we're going to talk about restrictive lung diseases.